Hi, everybody. It's welcome to the session titled Panel Discussion Understanding Thyroid Hormone Replacement Therapy. We're joined today with Dr. Francesco Celi. Dr. Celi is the William G. Blackard Professor of Medicine and Chair of the Division of Endocrinology, Diabetes, and Metabolism at Virginia Commonwealth University in Richmond, Virginia. Prior to joining the faculty of VCU, Dr. Celi worked for 10 years as clinical investigator at the National Institutes of Health, National Institute of Diabetes, Digestive, and Kidney Diseases in Bethesda, Maryland. He is a graduate of the University of Rome, La Sapienza, and a diplomat of the American Board of Internal Medicine with subspecialty in endocrinology, diabetes, and metabolism. Dr. Celi conducts both clinical and translational research, and his scientific interest is focused on the physiology and pathophysiology of thyroid hormone action as it relates to energy metabolism. Dr. Celi's clinical interests are thyroid disease with a special focus on thyroid ultrasound, fine needle aspiration biopsy, and multidisciplinary management of thyroid cancer. We also have Dr. Jacqueline Jonklaas, who is an endocrinologist at MedStar Georgetown University Medical Center in Washington, D.C. Dr. Jonklaas has obtained her MD residency and fellowship training at Georgetown University. Dr. Jonklaas is the director of the Georgetown Clinical Research Unit and has published research regarding treatment and outcomes in patients and thyroid cancer. She is the Chief Operating Officer of the American Thyroid Association. She has been a member of the Endocrine Society since 1997 and serves on the editorial board of the Journal of Clinical Endocrinology and Metabolism, and as a member of the Endocrine Society Self-Assessment Committee. Last but not least, we also have Dr. Lizzy McAninch. Dr. Lizzy McAninch is an endocrinologist and clinical associate professor at Stanford Hospital and Clinics in Stanford, California. She received her medical degree from University of Miami Miller School of Medicine. Her research focuses on understanding aspects of thyroid hormone metabolism and genetic differences that impact these pathways. And we will have a Q&A session after all three presentations have completed. And I present to you Dr. Jonklaas. Thank you.
Well, greetings, everyone. I'm very happy to be part of this event. And I'm going to be kind of starting off with some sort of basic tenets about the use of thyroid hormone therapy for patients with thyroid cancer, hopefully setting the background for the second two talks. So what I'll be talking a little bit about is testing of thyroid function, the targets that we're trying to achieve, and how we monitor individuals being treated with thyroid hormone. And then I'll talk a little bit about medications or supplements that could affect thyroid function, and end with just a little discussion of brand versus generic thyroid hormone products. So first of all, what do we measure when we're trying to assess thyroid function? And this little graphic is showing the pituitary gland, which makes TSH, which you're all familiar with from your biochemical testing, which acts on the thyroid gland, which then produces thyroid hormone. And the thyroid hormones feed back on the pituitary to complete this feedback loop. So when we're treating patients with thyroid hormone, we may either target a normal TSH, so a reference range of about 0.4 to 4.5. We may target a TSH kind of in the middle of that range. We may aim for a higher end of that normal range, or we may be trying to achieve further lowering of the TSH or TSH suppression therapy. So what's the theory behind TSH suppression. And again, that means basically lowering the TSH. So the idea is that the TSH from the pituitary could potentially stimulate any microscopic thyroid cancer cells or thyroid cancer cells that may be present. And so we want a low TSH to avoid stimulating thyroid cancer cells. And the way we achieve this is by manipulating the dose of thyroid hormone that then feeds back on the pituitary, so there's less TSH production. And so how we achieve TSH suppression is basically by changing the dose of thyroid hormone. So if the TSH is too high, we would increase the dose of thyroid hormone. If the TSH is too low, we would reduce the dose. And in general, TSH suppression is associated with better outcomes in thyroid cancer, except for the folks that have the lowest risk thyroid cancer. So the TSH suppression is mostly something that we use in people that have higher risk thyroid cancer. And in the individuals with the sort of highest risk cancer, generally there's an increased advantage to lowering the TSH to a very low value. So this is a little bit of a kind of moving target as we get more data, but just as a general kind of principle, if someone is low risk thyroid cancer, that their cancer is a low risk, they've had a good response to their therapy, we would generally aim for a TSH that's in the lower half of the normal range. If we are not quite sure how someone has responded to their therapy and we're still kind of monitoring to determine that, we may try and get the TSH just a little bit below the normal range. And then continuing that kind of theory, if you have someone who is at high risk, you would lower the TSH as much as you could. Intermediate risk, TSH below the normal range. And these targets would depend on the overall kind of health of someone who's being treated for thyroid cancer. So we do have to think about adverse effects of lowering the TSH too much. It can put a strain on the heart. It can reduce bone density. So when we're treating with thyroid hormone, we're not only thinking about the thyroid cancer diagnosis someone has, we're also thinking about the other medical problems also. And so it's an ongoing monitoring when we're treating patients. We follow the TSH. We can change the TSH by altering the thyroid hormone dose if we're not pleased with the TSH target. And again, we would increase the dose to lower the TSH and lower the dose to raise the TSH. And as you're all aware, we have a nice spectrum of thyroid hormone doses so that we can titrate to the TSH we think is best for someone. All right, so moving on to medications or supplements that could potentially affect a person who's taking thyroid hormone. So the TSH that we achieve is not only affected by the dose of the thyroid hormone that we're prescribing, it's also affected by how that dose is absorbed. And that can be in turn affected by other medications, supplements, food, fiber, gastrointestinal conditions, and potentially brand names versus generics. So this is a list of some of the medications that could potentially interfere with thyroid hormone absorption. So calcium, iron, proton pump inhibitors, which are a common medication used to treat gastroesophageal reflux and stomach ulcers. So this is just an example, I know, of some of the medications that can affect absorption. And just to give an example of one of the classic supplements that can affect absorption, this is calcium. And so here is the TSH in a group of individuals that are not taking calcium, so at 1.5. And then these same individuals are now taking their thyroid hormone with calcium, and you see the TSH has gone up. So again, calcium obviously being a common supplement, this is something we need to bear in mind. Another common medication, proton pump inhibitors. And if we just look at the right side of this graph, you see the baseline TSH of about 2.2 in patients who are not taking a proton pump inhibitor. And then we see the higher TSH with the ingestion of a proton pump inhibitor. So potentially we would have to increase the thyroid hormone dose to achieve the same TSH in someone taking a proton pump inhibitor. Another factor that can affect absorption of thyroid hormone is the proximity of the thyroid hormone to a meal. And so this is just one study showing that if patients took their thyroid hormone before breakfast, about an hour before breakfast, there's a nice low TSH. If they then took the thyroid hormone with breakfast, the TSH goes up, and you can also see it's very variable, and that may depend on the content of the breakfast. If you take the thyroid hormone at bedtime, the TSH is lower than with breakfast and is also a little variable. So either before breakfast or at bedtime are generally the times that we recommend taking thyroid hormone. So there are a number of different gastrointestinal conditions that can affect the absorption of thyroid hormone. And treating the gastrointestinal condition may improve the absorption, or alternatively, if the condition can't be satisfactorily treated, you would simply increase the dose of the thyroid hormone to achieve the TSH that you want. And just a couple of words about supplements. There are many different supplements that contain thyroid hormone, and this is something for everyone to be aware of. And so this is an example of a supplement that actually contains freeze-dried thyroid hormone. So just to be alert for these types of products. And this is just a study that took a number of different health supplements, 9 of them, and measured the thyroid hormone content. And you can see that some of these supplements had a lot of T4 and some had a lot of T3 shown in the red. So just a little, something to be aware of. And finally, just a quick word about brand versus generic thyroid products. So most thyroid products have really good quality control, but different products have different inert ingredients, and so there may be slightly different absorption. So in general, if we can, we'd like to keep individuals on the same formulation, so everything is kind of held steady. If a product has to be changed for whatever reason, maybe expense or change of insurance, we would like to recheck the thyroid function just to make sure that there hasn't been a change. And there's sort of mixed data. Some studies show that changing products may alter the TSH. Other studies show it doesn't change too much, meaning that the products are fairly equivalent. But just to be alert that if you have your product changed and you feel different or something doesn't feel right, it is worth rechecking the thyroid function to make sure that that isn't the issue. And I think that's my final slide.
Thank you so much, Jackie. That's an excellent segue to my portion of the talk. Let me get my slides up for you. So I'm Lizzy McAninch. I'm from Stanford University here in sunny California. So as Jackie mentioned, Dr. Jonklaas mentioned, the thyroid stimulating hormone stimulates the thyroid gland to make thyroid hormones in the flavor of T4 and T3. That's when you have a nice, normal thyroid gland in your body. Now, when you have thyroid cancer and have your thyroid gland removed, you don't have a thyroid gland producing these hormones. And the standard of care is to put people on levothyroxine. Now, levothyroxine is the drug name for T4 hormone. And I assume that if you are all thyroid cancer survivors, most of you have probably been on T4, levothyroxine. The amazing thing about T4 pills or T4 in general is that it can be converted to T3 in your system, in your body tissues. So the standard of care is to start someone on levothyroxine and allow the T4 to be converted to T3 in the tissues, in the body tissues. And remarkably, patients on levothyroxine have stable levels of T3 in their bloodstream because their tissues are converting the T4 to T3. Now, as I'm sure many of you heard or experienced yourselves, not every patient is perfectly tolerant of this. It doesn't completely perfectly replace a normal thyroid gland like you had before your surgery, if you had normal thyroid function before your surgery. So there's this kind of question if and how we can improve the standard of care. Is there some ideal new treatments that would be available to provide you both T4 and T3 in the correct ratio of 14:1 as it's normally made by the human thyroid gland? There's nothing yet on the market that does this perfectly, but we're trying our best. And so let's talk about the forms of thyroid hormone that are in the market in the US. Okay, so this is a complicated slide, but we're going to go through it slowly together. Okay, so levothyroxine is the one that most of you are on or have been on. It's a synthetic T4 drug, and your body tissues convert the T4 to T3. So the wonderful things about levothyroxine are that it stays in your bloodstream for weeks. So if you miss a pill, you're not going to be hypothyroid. It results in stable blood levels of T4 and T3. It's FDA approved and monitored, so it's safe and efficacious. It works. But some potential problems with this pill are that maybe people have slightly higher bloodstream T4 levels than normal when they had a thyroid gland, and maybe slightly lower T3 levels. And about 80% of patients are satisfied with this treatment in general, in theory, but about 15% report residual symptoms of hypothyroidism. And we don't know exactly why that is. We don't know the exact mechanism behind that. Okay, so the second pill on the market in the US is called liothyronine. This is a synthetic T3 pill. And the issue with this pill is that it has a very short lifespan in your bloodstream. So after you take it, you get a high bloodstream peak in a couple hours, and then it goes away in a couple hours. So you get high bloodstream peaks and low valleys. So it's kind of like being on a roller coaster in terms of T3 levels in your bloodstream. It's FDA approved and monitored, so it's safe and efficacious, but there are some safety concerns, but we can talk more about. You need to take it ideally multiple times a day. Once a day results in these big peaks and valleys, but that's been shown by Dr. Jonklaas and Dr. Celi to be improved by taking it twice a day or 3 times a day or 4 times a day. And it's not usually given alone, except in preparation to receive radioactive iodine, which many of you have probably done. Okay. The third option for thyroid hormone replacement in the US is something called desiccated thyroid. Desiccated means dried. So this is a dried pig thyroid gland that's taken to a lab bathed in chemicals, and the thyroid hormones are extracted. So 100 years ago, desiccated thyroid gland used to be natural, meaning that they literally dried up thyroid glands and ground them up and put them in pills. But now it's not so natural because there's all these chemicals involved in extraction of the hormones and making sure the pills contain the correct hormones and T4 and T3 and maybe some other stuff. And they're put into pills with dyes and fillers. But these pills contain T4 and T3. So in the US, this is the only pill that we have that combines both flavors of thyroid hormone, T4 and T3. The one issue with it potentially is that it has a ratio of T4 to T3 of 4:1, which is the ratio naturally found in pigs. But that's more T3 than humans have on their own. We have more of a ratio of 14:1-ish. And you have all the same things of the T4 and the T3. So all the problems of T4 and the benefits of T4 you have because it's T4 and T3 in this pill. So you have steady levels of T4 in the bloodstream on top of peaks and valleys of the T3 in your bloodstream. It's not FDA approved or FDA monitored, so there's consistency concerns. So if you're on desiccated thyroid only, you generally have low bloodstream T4 levels, fluctuating T3 levels, a big peak after you take it, and then a fall in your T3 levels. And we're unable to adjust the T4 or T3 ratio. It only comes in one ratio, that's 4:1 ratio. There's questions about consistency because it's not FDA approved or monitored.
And first of all, thank you for the invitation. And hopefully you can see my slides. I will focus my presentation on T3 containing therapies. First off, I want to advance the slides and it doesn't work. Okay, great. I do conduct research on T3 containing combination therapy for patients who have thyroidectomy. And I'm also a consultant for some pharmaceutical companies that are developing thyroid-related medication with the goal of providing for some individuals better treatment. So what I'd like to talk today about is, again, just jumping on Dr. McAninch presentation and as a segue, additional information on T3 containing formulations, and then providing some clinical data on combination therapy and thyroid extracts. Then I would like to discuss the pharmacologic characteristics of liothyronine, because this is probably one of the most commonly non-levothyroxine treatment performed, particularly in patients who are not feeling okay on levothyroxine only. And then I would like to give a very personal approach and clinical considerations relative to this, I cannot call them alternative therapy, but therapy which are not standard for the treatment of hypothyroidism. So again, liothyronine is a synthetic form of T3. And in terms of equivalency, so the equivalency of, say, 75 micrograms of levothyroxine is roughly 25 micrograms of liothyronine. And this is something that we demonstrated experimentally, giving 3 times per day. So this is in a complete experimental context that is very difficult to replicate in clinical practice. The reason, as alluded before, why we give multiple infractionated doses is that there are significant peaks and troughs, meaning the levels go up and down in time, with a peak that is quite quick and significant in 2.5 hours after the assumption of the medication. Importantly, the type of formulations in commerce right now are very limited, so 5, 25, and 50 micrograms. Relative to the desiccated thyroid extracts, there are many formulations in the market with quite a large range of dosing. They are at this time, they're all derived by swine thyroids, and they're a mix of T4, T3, and potentially other compounds. Those are, as Dr. McAninch mentioned, those are very purified extracts, but potentially there are other contaminants or other substances aside T4 and T3. One important consideration is that the ratio T3 to T4 is 1 to 4, roughly, which is very different from the ratio of T3 to T4, which occurs in circulation. Then in terms of equivalence in potency, and here we refer potency as amount equal to generate the same level of TSH as levothyroxine. Roughly 100 micrograms of levothyroxine equates to 68 milligrams of desiccated thyroid extract. And this is a work of Dr. Hoang at the Walter Reed Hospital. So again, how do they work? Do they work better or not? Here, in one single slide, I try to summarize the probably good 15, 20 years worth of research with many investigators. So several clinical studies in the aggregate have failed to show significant differences between levothyroxine and T3 containing therapies as it relates to well-being, weight, and other symptoms. Now, there are plenty of technical considerations that affect the interpretation of data. So duration of the study, type of formulation, study design, etc. And to some consistency, though, a subset of individuals appear to, quote, respond. What does it mean, respond? Some individuals feel objectively better, particularly on T3 containing treatment. Some individuals tend to have a lower weight, and there is some evidence that genetic background, meaning polymorphism in genes that encode proteins that are involved in the metabolism of thyroid hormone, may respond better to T3 containing therapy. Now, keep in mind that all of these studies are relatively short term, meaning maximum 6 months. And so in essence, we do not know what happens in the long run. And also there is no apparent difference in adverse events. So that's where we stand from at this time in terms of research. So now I'd like to share some information on liothyronine because this is where I do most of my clinical research. So again, the major concern is that liothyronine has a short half-life. What does it mean? It means that the level fluctuates after the administration. Also, there are major considerations due to the higher potency than levothyroxine and the limited dosage available in commerce. So that leads to major concern for potential toxicity, particularly in the cardiovascular system. And then also because of the fluctuation in the serum during administration, the question is it going to work well or not? And again, this is just a slide from one of our works that shows the immediate increase in T3 level after administration, and then here it disappears. And again, this is an environmental an experimental environment which has nothing to do with the clinical practice. In this case, we gave a very large dose of T3. And that leads to a clinical question. How important is the peak level relative to the effects? So T3 binds to nuclear receptors, so that it takes time to generate effect, at least in terms of transcription of genes. And the question is there any acute effect or not? If there is some acute effect, we may see at the time or close to the time of the peak level, and this is in panel A, we should see some effect, at least in the target tissues that are directly exposed to this onslaught of thyroid hormone. Conversely, if all the effects we see are related to genomic effect, meaning transcription of genes, then this peak may not be too much of a concern. And we try to address this question at least in one single dose in acute effect on this recent manuscript. And to make this story short, we had healthy individuals, kept them in a very controlled environment, and gave them either placebo or a very high dose of T3, and literally look what happened at around this time where we had an increase and then a drop in T3 level. To make the story short, we saw no effect in heart rate, blood pressure, cardiovascular function, or energy expenditure. So what is the message? The message is that maybe, just maybe, there is really no immediate clinical relevance of one single peak of T3. That really needs to be looked in the larger context. So let's put the clinical hat. How do we translate when we sit in front of a patient? What can we do? So why should I consider as a clinician or as a patient investing into a different therapy compared to levothyroxine? Well, again, as we said, there is some individual who feel they're feeling better. Maybe they lose a bit of weight, maybe their cholesterol will be lower. And again, from what we see in the studies, and I want to point in these studies, there is no evidence of significant adverse events in the short term. It may be a physiologic replacement when we discuss in terms of combination therapy or natural treatment as desiccated thyroid extracts. So those are the pluses. Now let's go on the why no. First and foremost, T3 containing therapy are contraindicated in patients who are pregnant or who are planning pregnancy. This is extremely important. I want to stress it a lot. Reason being that the T3 levels, the placenta would filter the T3, and the patient and the fetus may be hypothyroid. Then the skeptical eye says, well, there is really no convincing evidence of clinically significant improvements. And then, as I said, although there is no evidence of adverse event in clinical studies, unfortunately, we have plenty of events of toxicity by overdosing, either by patients who inadvertently got the wrong message, or, and it's sad to say, unscrupulous colleagues that give toxic doses of T3 containing therapy. Also, there is an absence of long-term studies. And do not forget that now we are going on complex regimens, particularly in combination with levothyroxine and liothyronine, whereby we need to take 2-3 times per day, two different type of medications, etc., which inevitably lead to some degree of fluctuation in the thyroid hormone levels. Now, also the costs are a concern. because now we're giving at least 2 different type of medication, or for the desiccated thyroid extracts, probably the price point is a bit higher compared to levothyroxine formulation. And as it relates to desiccated thyroid extracts, again, this is literally ground meat that gets somewhat purified, but it's definitely directly coming from animals with all the concerns associated with slaughterhouse, etc. So let's say and again, I'm completely agnostic when it comes to make a decision. And I would like to share my personal, and again, this is purely personal approach. I'm not talking for the organization of whom I'm a member. I'm not talking for my university. This is just Francesco Celi. So what I usually do, I first go through the process of optimizing the standard therapy. So I want to make sure that the levothyroxine treatment is on target, and the target is the adequate target as related to the patient condition. Since we are talking in the environment of thyroid cancer survivors, the TSH target becomes extremely important. Also, I do engage in a careful assessment of other comorbidities or factors that can cause symptoms that people may attribute to thyroid disease or not. What else is going on? Is there a component of depression? Is there a component of another autoimmune disorder? Is there a component of another disease such as anemia, etc.? And we want to point them out and work on that. And then I have a very frank discussion of the potential risks and benefits. So I'm not selling snake oils. I don't know whether it's going to work. I have no ability of saying in advance whether a patient will benefit or not. This is something that it's a journey if we want to go into there. And I engage with patients in a shared determination of what I define as index symptoms. So in other words, what is the symptom that bothers you the most, and you describe this is due of the thyroid. This is because of thyroid. And then we look at the symptom and see how we go on therapy. So again, we generate a therapy targeted, and sorry for repeating, targeted to the target TSH and thyroid hormone within normal range. So we cannot allow elevated levels of T3. We cannot allow suppressed level of T4. That would be potentially unknown and really not that physiologic anymore. And then I reassess after 3 to 6 months. And if it works, it's great. Do I know how often it works? It's very individually, and I really don't want to make major claims at all. If it doesn't, my question to the patients is, why do we want to engage in this complicated and costly treatment if there is really no benefit? And so that's my conclusion. We really, as scientists and clinical scientists and doctors, we really need to be humble and say that there is plenty of unknown. And my personal approach is a shared and informed decision-making process. And this is crucial for therapeutic success. And honestly, I know it takes time. I know it takes time sitting in front of patients and having these discussions, which may not be all optimistic, but we really need to be honest. And I don't want to lose patients that then may end up treated by unscrupulous colleagues. And also, and I know this audience is incredibly receptive, and we're so grateful to you. Please stay tuned and on the lookout for clinical studies, because we really need partnership in research and in science. And again, thank you for the opportunity.
Okay, we do have several questions ready to go. We'll start with this one. Is TSH suppression for people with all sorts of thyroid cancer?
I could go ahead and maybe start that one. So it is not part of the management of individuals that have medullary thyroid cancer, because that doesn't seem to be affected by the TSH so much. So it is just something we use for papillary and follicular thyroid cancer. And not every patient with papillary thyroid cancer needs TSH suppression. It depends on the risk level, what the initial pathology was like and how they've responded to that therapy.
For a patient that has one lobe removed, how do you determine the dosage for thyroid hormone replacement?
So the people who've just had one lobe of the thyroid removed, not everyone necessarily needs thyroid hormone. It depends on what happens to their TSH after the surgery. I think about maybe 50%, something like that, of people who have had half their thyroid removed, the TSH goes up sufficiently that we would want to start thyroid hormone. And if we do that, we would decide what TSH is best for that patient and adjust the thyroid hormone, based on the TSH.
And how often should you check your TSH level? Should the level be in the middle of the range?
I can take this one.
Yes.
So TSH ranges that are appropriate for you are specific for your degree of thyroid cancer in terms of your seriousness or aggressiveness of your thyroid cancer and your risk level, like Dr. Jonklaas presented. So everyone's TSH goal is specific to them for their flavor of cancer. Now, how often should you be checked is very interesting question. Likely you're going to be checked more often in the beginning years or months while we get to the target. And once the target is reached and we get a few more years out and we're more reassured that you're stable, your disease is stable, sometimes you just check once a year even on stable, long-term chronic thyroid cancer patients.
Is there any indication?
I'm sorry, if I can jump in. What makes the dosage changing is two things. One is patient's mass. So major changes in body weight in one direction or another would probably require an adjustment in therapy. And the other potential effect is substances or conditions that can affect the absorption of levothyroxine. So in this case, starting or stopping antacids that can affect it. Conditions such as bariatric surgery, malabsorption, celiac disease, etc., that can affect the absorption. They are all important conditions that may cause a different requirement of levothyroxine.
Is there any indications that Synthroid can cause hot flashes?
I'll take this one. So if you take levothyroxine at doses that lower your TSH, so at high doses, more high than a normal thyroid gland would usually make, that can cause symptoms of hyperthyroidism, too much overdose of thyroid hormone. And so those symptoms can include feeling hot, insomnia, anxiety, maybe some shakiness, tremor. And when a patient does have a TSH goal on the low side because they maybe have some residual thyroid cancer or higher risk thyroid cancer, those symptoms of maybe too much thyroid hormone will have to be weighed with the risks and benefits of the TSH suppression goal. So sometimes we allow the TSH to rise a bit in those patients, even if their goal was a low TSH, if they're too symptomatic from it.
Is there any percentage of total thyroidectomies survivors over 50 that need to take T3 supplement because their bodies have slowed down or stopped converting from T4 to T3?
I think that's a question and answer for Dr. Celi. That's one of his areas of expertise.
Thank you. And my answer is a resounding, I don't know. Again, we really need to individualize the treatment. Personally, I don't make a point on the T3 levels per se. Keep in mind that what we're looking at is the concentration of T3 at the cellular level. So there are multiple steps between circulation and thyroid hormone effect. Again, my approach is very not skeptical, agnostic. If a patient does not do well and there is no other obvious or not so obvious condition that can prompt the onset of new symptoms that can be associated with hypothyroidism, then I may want to try to make what I call a therapeutic contract. So let's give it a try, give our best try, curb your expectations. Because and again, at this point in my research, I really cannot pinpoint which individual may or may not respond.
If a patient was taking their levothyroxine before bed and they're having problems sleeping, would you suggest that they start taking it in the morning instead?
Maybe I can take that. I think one thing to remember is a lot of the symptoms of your thyroid dose not being correct overlap with symptoms of other things. And so if someone is taking the thyroid hormone at bedtime and has trouble sleeping, it could be that the trouble sleeping is due to menopause or stress or, other things. But having said that, when you take levothyroxine, the peak of the thyroid hormone is about sort of 3 hours or so, after you take it. So it's possible that could interfere with sleep. I'm not sure it's been really tested, but I think it's worth, if someone is taking their levothyroxine at night and have trouble sleeping, I think it's worth a trial of taking it in the morning and see if it fixes the problem. If it doesn't fix the problem, then, if the bedtime taking of it was more convenient, then, you could go back to that. So it's possible, but I don't know that we could prove it without trying it in that person who's having that issue.
And this is a lifetime treatment. So whatever makes patients' life easier, by all means. Generally speaking, whatever works for the patient works for us. Our recommendation is be consistent in what you're doing. That's with levothyroxine. There is probably some information that some of the audience may be aware of, particularly if you're of Italian descent, about the potential interference with espresso. We Italian, if we don't get espresso right away, we go crazy. What happens? There is some reduction in absorption. But if you really cannot do it, as long as you take the same espresso and the same amount of thyroid hormone, it's totally fine with us. And this is just an example.
Should my endocrinologist be testing for T3 as well as T4?
I guess the question is, what do you do with this information? And honestly, there is little indication, if none, in the treatment of hypothyroidism, because again, what we see is the endpoint of the thyroid hormone action. It might provide what I call it circumstantial evidence if the T3 levels are really low. Keep in mind that low T3 levels, even in patients who are treated for hypothyroidism, can be low in case of ongoing disease. And that has really nothing to do with the thyroid hormone replacement per se. So again, the question is why spending extra money? Why for a test that we don't know much what to do? Same story, multiply many times. What to do with reverse T3? Honestly, I don't know, and I guess Dr. McAninch and Dr. Jonklaas can dive on this question as well, because we get these questions many times. So my answer, I don't know what to do it. I don't want you to spend money on.
Yeah, so if you're doing great on levothyroxine only, checking T3 probably won't change what you do, won't change your management, won't change your plan. So it doesn't make much sense to do tests that means nothing's in terms of outcomes for you. If you and your doctor are considering trying combination therapy with T4 and T3, like Dr. Celi said, it's interesting to think of monitoring your T3 levels in terms of what are your levels before and after that trial of therapy. Now, whether they get better or not, we don't know. And we don't know if that correlates with improvement side effects. But it is interesting. And I check it for my patients that are embarking on a trial of combination therapy.
Can exercise affect how levothyroxine is absorbed?
I'm not aware of any data that would affect absorption. I think if someone is exercising and they've increased their lean body mass and maybe lost a little fat mass, they may have a different requirement for thyroid hormone in terms of the dose, but I don't think the exercise itself affects the absorption. I don't know whether Dr. Celi or Dr. McAninch have different thoughts about that.
I agree. Maybe when you start exercising, you're more hungry and maybe eat sooner, like your breakfast sooner after the pill. And you really need a good half an hour to 1 hour before eating breakfast on an empty stomach with that thyroid pill alone in your belly to make sure its absorption is optimal.
We would always encourage exercise.
Exercise is good.
Thyroid hormone and exercise, yeah.
Along those lines, can levothyroxine cause muscle aches as a side effect?
Severe hypothyroidism and severe hyperthyroidism can be associated with myopathy, which is pretty severe, but usually it's at the two extremes of the range. Some individuals complains of cramps and very difficult to pinpoint symptoms, which may be associated with I want to use the term drug intolerance rather than allergy, because again, levothyroxine per se is as natural as it gets. Some individuals are particularly intolerant to excipients or medications, and they can give a very wide range of symptoms and signs.
A common medication that people who are taking thyroid hormone may also be taking is a statin. And those types of medications, some people do get kind of muscle aches and cramps or muscle aches with statins. So it could possibly be another medication if someone is taking, a statin.
Is there any information regarding depression and before starting T3 and then improving their situation after starting T3?
I'll take this. So yes, when a patient has a normal functioning thyroid gland that's making T4 and T3, It's not uncommon for people with normal thyroid glands to have depression. So it's a very common disease. And we see that after thyroid surgery and putting the patient on levothyroxine only, there may be slight increase in depression. Now, we know that the brain is very T3 sensitive. The brain converts a lot of T4 to T3, and it contains a lot of thyroid hormone receptors. And so you can hypothesize that maybe T3 is really important for the brain. And so people with hypothyroidism can feel tired, have brain fog symptoms, foggy thinking, depressed mood. So a lot of brain symptoms can come along with hypothyroidism. And I believe that the psychiatrists have better literature on this than the endocrinologists do, or at least acknowledge. So some psychiatrists really prefer treating hypothyroid patients with depression with both T4 and T3 and have seen improvements. I have as well. So really it's an individual choice, a therapeutic decision to embark on a trial of combination therapy. In some patients with depression or other symptoms, there are residual symptoms, do feel better on a little bit of T3.
Why would a patient need lower doses of levothyroxine as they've aged?
Actually, that's fairly common, and that's due to the loss of fat-free mass. So, sorry, the thyroid hormone replacement dose is usually 1.6 microgram per kilo, but that's on the average. I determine normal, but on the average individuals. As individuals age, there is a significant loss of muscle mass, and that, in essence, decreases the effective weight for the patient and the effective needs for thyroid hormone.
Is there any information regarding absorption issues when using other medications such as Pepcid, omeprazole, Nexium, Zoloft?
So that entire group of medications, if it affects the pH of the stomach, we do think it alters thyroid hormone absorption. And because those medications are long-acting for the most part and change the gastric pH throughout the day, probably the best way to improve the absorption is actually to increase the dose of thyroid hormone. For things like, calcium and iron, we tend to try and separate them and have them at different times of day, so absorption is not affected. But I think for things like proton pump inhibitors and things, because they are so long-acting, the best way may be to change the thyroid hormone dose to counter the effect.
We'll try to squeeze one more question in. Dr. Celi, did you mention that T3 can be impacted by the parathyroid and or hypoparathyroidism?
No. No, T3 levels, even in individuals who are stable in terms of dosing, can be affected by other conditions. So, and this is the so-called non-thyroidal illness that affects the conversion of T4 into T3. So if an individual gets a pneumonia, for instance, their T3 levels will go down. Or if an individual becomes septic, their T3 level go down even if they receive the same amount of thyroid hormone. But this is a very specialized situation that really has nothing to do with the day-to-day life of individuals who are on chronic levothyroxine therapy. I hope it clarifies that.
Okay, and thank you, doctors, for your time and your openness and willingness to answer questions. And with that, I thank you again and hope you have a wonderful day, evening, morning. That's it.
Thank you
Thank
for
you.
hosting
Thank
us,
you.
Matt. Thank you.
Thank you for inviting. We're so
Thank you.
grateful. Bye-bye.
Bye-bye.